Alterations in cardiac output and tissue perfusion. Arrhythmias. The cardiac rhythm is the pattern of the heartbeat. Diagnosis of this rhythm can help identify issues the client may be having and guide the client's treatment. The usual rhythm is the normal sinus rhythm. An arrhythmia or dysrhythmia is a conduction disorder and can affect the cardiac output. Arrhythmias are generally caused by cardiac disease, but it can also be caused by the drug, therapy, electrolyte imbalances, acid-base imbalances, hypothermia, or age-related changes. What I want you to be very familiar with, anytime we have any type of arrhythmia, whether it's just a fast heart rate or a slow heart rate or an abnormal heart rate, it is going to decrease our cardiac output. During the assessment, it's important to determine if the arrhythmias are perfusing. So check the peripheral pulses at the same time that you're auscultating the apical heartbeat and see if they are the same. This shows your heart rate, what it looks like on an EKG. So let's look at it a little bit more in depth. When you look at the heartbeat, if you can see, each tiny square here measures 0.04 seconds. We are going to measure the PR interval, and that normal interval is going to be 0.12 to 0.2 seconds. A normal QRS will be 0.6 to 0.06 to 0.1. A new normal QT measures 0.36 to 0.44. It could be abnormal because of a family issue, hypercalcemia, or cardiac glycoside toxicity. So when we're looking at an EKG, we need to look, first of all, is there a P wave in front of every QRS complex? Is there, we're wanting to know, excuse me, we're looking at the rate, we're looking at the rhythm, is it regular or irregular? We're going to look at the PR interval, the QRS complexes, the ST segment, and the T rate, T waves. We want to know if they're upright or if they are inverted. Now for NCLEX, what you need to know, and I will be pointing those out as we go, is fast, slow, no go. Okay, so first of all, we want to look at our strip here. We always look to see, do we have a PR or a P wave in front of every QRS interval? And yes, we do. So we know that that is a sinus rhythm. That P wave is going to be initiated from the atria of the heart. So we know this is a sinus rhythm. We want to know what the rate is. If it's between our normal 60 to 100, we know that is a normal sinus rhythm. Again, the SA node initiates the impulse. That impulse will then travel to the AV node within 0.12 to 0.2 seconds, and the ventricles will then depolarize in hopefully 0.1 or seconds or lower. That impulse occurs regularly. The atrial arrhythmias that originate in the sinus node include sinus bradycardia and sinus tachycardia. Atrial arrhythmias that develop in sites outside the sinus node will include premature atrial contractions, a supraventricular tachycardia, atrial flutter, and atrial fibrillation. So once again, we look at the rhythm. Do we have a P wave in front of every QRS? When we look at our atrial rhythms, we're looking, first of all, if it's a slow rhythm, a bradycardia. That is going to be slower than 60 beats per minute. It is an arrhythmia that's proceeding normally through the conduction pathway, but it goes at a slower than usual rate. We often see bradycardia in a healthy athlete, heart disorders, increased intracranial pressure, hypothyroidism, digitalis toxicity, and the danger is that the slow rate may be insufficient to maintain cardiac output. We treat it by administering atropine sulfate, which is a cholinergic blocking agent given IV to help increase a dangerously slow heartbeat. So atropine is indicated for bradycardia in this situation. Contraindicated in angle closure glaucoma, acute asthma, myasthenia gravis, and GI and GU obstructions. Adverse effects. Well, we're giving it to increase the heart rate, but it can increase it too much. It also is going to dry things out. This is a drug that's often given in surgery to help prevent over secretions, so it dries up some of the secretions. It can cause urinary retention, decreases sweating and salivation, can cause constipation. It increases intraocular pressure, can cause delirium and confusion. If we overdose or it is toxic, fluid therapy. For severe delirium, we can give physostigmine, which can also cause some seizures and cardiac standstill. It does interact with other things that are drying, such as antihistamines, and it can increase the effect of digoxin. So another cardiac arrhythmia would be our sinus tachycardia, where the arrhythmia proceeds normally through the conduction pathway, but it goes at a faster rate than usual. And our high rate, again, is going to be 100. And that would go from 100 to 150 beats would be considered sinus tachycardia. So it can be caused as a physiological response to strenuous exercise, anxiety, fear, pain, fever, hyperthyroidism. But it can also be a compensatory mechanism for hemorrhage, shock, or hypoxemia. Then we have a premature atrial contraction, or a PAC, which we have neural tissue in the atrial conduction system that initiates an early electrical impulse. This is identified by an irregularity in the underlying rhythm. And this is what we have a picture of up top. Causes can be caffeine, nicotine, or other sympathetic nervous system stimulants, heart disease, metabolic disorders, and hyperthyroidism. Usually this can be treated by eliminating the cause. Once again, for NCLEX, you need to know fast, slow, no-go. So you need to know sinus bradycardia and sinus tachycardia. So now looking at our supraventricular tachycardia. This is an arrhythmia abbreviated as SVT, and we have a heart rate that has a consistent rhythm, but it beats at a dangerously high rate. So it's going to be over 150 beats per minute. The diastole is shortened, so the heart does not have sufficient time to fill up. So the cardiac output can drop dangerously low. These clients may experience chest pain, tachycardia, well, they do have tachycardia, angina, hypotension, syncope, and reduced renal output. If we have poor cardiac output, that affects our urinary output because we're not getting the blood flow through the kidneys. We treat it with digitalis, adrenergic blockers, calcium channel blockers, or adenosine to rapidly convert the rhythm. Atrial flutter is a single atrial impulse outside the SA node that causes the atria to contract at an exceedingly rapid rate, and it can contract at 200 to 400 contractions a minute. But the ventricles are contracting at a slower rate. What we see with a flutter is going to be kind of that sawtooth pattern or those flutter waves. Atrial fibrillation is something that you need to be familiar with because this is a very common issue in a lot of our clients with heart disease or even some of our older clients. Atrial fibrillation, the atria, instead of contracting, are actually just quivering. Those ventricles will respond to the atrial stimulus at a random rate. So this causes a very irregular ventricular heart rate. And it may be too infrequent to maintain adequate cardiac output. Complications, the blood is just kind of sitting there in the heart. It's not being pumped out. The heart's upper portion of the heart is just quivering. It's just kind of shaking. It's not pushing the blood through the heart, so it sits there. So the development of clots is a possibility. One of the biggest causes of stroke is atrial fibrillation because we have the development of clot. We treat it with medical or chemical cardioversion, so we try and use those medications first. We can also treat it with anticoagulants. We want to keep the blood thin. We want to prevent that clot formation. So heparin might be prescribed initially if that arrhythmia persists longer than 48 hours. Coumadin or warfarin is prescribed for persistent atrial fibrillation. We can also do what we call an elective cardioversion, where we actually go in and we shock the heart to try and briefly stop it so it will return in a normal sinus rhythm. We can also do a surgical management where we restore that normal conduction pathway in the atria by eliminating some of those rapid firing ectopic pacemaker sites. It's called ablation. Atrial fibrillation that has a rapid ventricular response, we call this AFib with RVR, can have a dangerously high heart rate that requires us to slow that heart rate as quickly as possible. So we have a client that presents to the emergency department with complaints of syncope and chest pain. The EKG results indicate the client has supraventricular tachycardia. The nurse anticipates the treatment for this arrhythmia is and that is digitalis. It's going to help slow that heart rate down. Heart block are disorders in the conduction pathway that interfere with the transmission of the impulses from the SA node through the AV node to the ventricles. We have different types. We've got first degree, second degree, and third degree. Third degree is considered to be a complete heart block. First and second degree heart block, we just have a delayed impulse going through the heart. With a complete heart block, again also known as the third-degree heart block, the atrial impulse never gets through, and the ventricles will then develop their own rhythm independent of the atrial rhythm. That ventricle rate will be pretty slow, usually 30 to 40 beats per minute. This requires pacemaker insertion. Premature ventricular contractions, or PVCs, is a ventricular contraction that occurs early and independently in the cardiac cycle before the SA node initiates an electrical impulse. So no P wave will precede that wide, bizarre-looking QRS complex. These clients, if they begin to have too many PVCs, may develop pallor, nervousness, sweating, faintness, or a fluttering sensation in their chest. If they just have one ever so often, it's not a big deal. You know, we want to keep an eye on it, but we're not overly concerned. It's when they begin experiencing more. So that occasional one can be harmless and might just be related to anxiety, stress, fatigue, alcohol withdrawal or tobacco use. But it can be a precursor to a lethal arrhythmia. So this is something you should be familiar with. If we have 6 or more PVCs per minute, if we have runs of what we call bigeminy, where every other beat is a PVC, if we have 2 PVCs in a row or a couplet, if we have runs of PVCs, which include 3 or more PVCs in a row, and that's called ventricular tachycardia. If we have multifocal PVCs, which is what you see in your slide, so the configuration of that wide, bizarre QRS complex looks different. That is a multifocal, so it originates from more than one location in the ventricle. Or we have a PVC whose R wave falls on the T wave of the preceding complex. When dangerous PVCs occur, the client will be given an IV bolus of an antiarrhythmic medication, and that may be lidocaine, followed by a continuous IV infusion to help try and convert those arrhythmias. This is ventricular tachycardia, where we have a single irritable focus in the ventricle that initiates and then continues the same repetitive pattern. The ventricles beat very fast, 150 to 200 beats per minute, and the cardiac output is significantly decreased. This is a fast rhythm that you need to know. The client can lose consciousness and become pulseless depending on how long this arrhythmia is present. Ventricular tachycardia sometimes will end abruptly without any intervention, but often it will require defibrillation and it can progress to ventricular fibrillation. And this is ventricular fibrillation. It is the rhythm of a dying heart. You need to know this. PVCs or ventricular tachycardia can precipitate it. The ventricles are not contracting effectively. They are just quivering, and there is no cardiac output. These clients require cardiopulmonary resuscitation, aka CPR, and defibrillation. So a client is experiencing premature ventricular contractions and reports a fluttering sensation in the chest. The nurse explains that the causes of the client's symptom as this answer is B. The ventricular contraction occurs early and independently. Cardiac arrhythmias are going to cause the client to feel weak, tired. They may experience anginal pain. They may feel faint, have palpitations, experience hypotension, pale, cool skin, and they may have mental status changes. We're going to diagnose by looking at a monitor rhythm strip or a 12-lead EKG to help identify those arrhythmias. We can also do an electrophysiology study, which produces actual arrhythmias by stimulating the structures in that conduction pathway. Helps determine the best method for preventing further arrhythmic episodes and can eradicate tissue in the area of the heart that's producing the arrhythmia. We treat it with drug therapy. The oral and IV antiarrhythmic drugs are used to treat clients with arrhythmia. Class 1 might be your procainamide hydrochloride, your isoproterenol. Your amiodarone would be your class 3, and verapamil, class 4. We can do elective electrical cardioversion. This would be in a non-emergency, and it's a procedure that stops that rapid but not necessarily life-threatening atrial arrhythmia. We can defibrillate only for a life-threatening ventricular arrhythmia. So in pulseless ventricular tachycardia, ventricular fibrillation, and sometimes as a last-ditch effort, we may use it in asystole, although it is usually almost always non-effective in asystole. Survival rate with defibrillation done within the first 3 minutes of pulseless VTAC or VFib is 70%, but it decreases 7 to 10% every minute thereafter if we delay defibrillation. So types of defibrillators include that AED, the automated external defibrillator, which you train with in your CPR classes, located in some brand new vehicles, located in some of your stores or schools or other facilities. It may be a fixed rate or asynchronous mode pacemaker, an automatic implanted cardioverter defibrillator is something that's implanted like a pacemaker, and whenever it senses these shockable rhythms, it will cause it to shock the client. We can also use the one where we have the patches or the pads or the paddles that we physically apply to the client's chest and defibrillate that way. We can insert a pacemaker, which provides an electrical stimulus to the heart muscle to treat an ineffective bradyarrhythmia, so a slow one. We have different types of pacemakers. We've got that demand mode pacemaker that self-activate when the client's pulse falls below a certain level. We have a fixed rate where it produces an electrical stimulus at a preset rate despite the client's natural rhythm. And we have these pacemakers can be permanent or temporary. Excuse me. We can also do the radiofrequency catheter ablation, where we destroy some of those arrhythmia-producing tissues. Complications of that include bleeding, perforation, a thrombus, and pericardial tamponade. So nurses need to educate on any procedures or equipment, medication regimen, and post-pacemaker placement. We have to immobilize the arm on the insertion site of the chest because those wires are not permanently seated in the heart tissue immediately post-operative. So usually for at least the first 24 to 48 hours, we have to immobilize that arm. And this is very important when they may have to go for a postoperative x-ray the following morning. Instruct your radiology department. Do not allow them to pull their arm forward or above their head. This strip shows an AV paced rhythm. So we have an atrial paced and a ventricular paced rhythm. The AV paced rhythm has two pacer spikes. If it is an atrial paced, it will be just a single spike. If it's a ventricular paced, we'll just have a singular spike. The difference is where that spike occurs. If it's right before the QRS, that's ventricular. If it's a little distance away, that will be your atrial. Having both of them, we have a electrode in both areas. The bottom strip is showing asystole. This is considered flatline or cardiac standstill, and there is no discernible rate or rhythm. So now we're looking at our ST segments. When we look at a heart rhythm, we're wanting to know if we were to lay a ruler or a piece of paper across the line, would it all be basically at the same level? But if you look here from our QRS, S being the last part of our QRS complex, and then our T wave is that wave behind the QRS. If that space between those two is elevated, or if it is depressed, that is telling us this client is having a myocardial infarction. So they're having a ST elevated MI or STEMI, or a non-ST elevated MI or a non-STEMI. So which of the following statements would require additional education to the client and their families regarding permanent pacemakers? D. Resume normal activities, including lifting after the pacemaker insertion to avoid arm swelling.